Well, good afternoon, everyone. This is Brian Robson, the Executive Clinical Director at Healthcare Improvement Scotland, and welcome to the fifth in our series of QI Connect webinars. We're now midway through this series, and all the earlier webinars are available on our back catalogue. This series arose from a request from our national clinical leads here in Healthcare Improvement Scotland to connect frontline clinicians interested in quality improvement with international leaders in the field of improvement. They ask that we make the sessions short, accessible and recorded so that they can access them at a time that suits them. We have a range of opportunities for you to actually be involved in the session today, and I'm going to hand you over to Lisa, who's going to explain to you a little bit more about WEBEX and how you can interact with us today. Good afternoon, Lisa.
Thanks, Brian. I just wanted to run through a couple of quick housekeeping slides to get us started. You'll notice on the right-hand side of the screen that you'll see a chat function box. What we'll do is, throughout the call, if I could really encourage you to get involved in the discussion and chat throughout, ask any questions that you want to pose to the presenter, and we'll address them at the end of the session. If you're having any technical difficulties, you can either message using the chat function the event manager, or you can call the number that you see on screen, and I'll try and provide some technical support if I can. Okay, so on the top right-hand side of the screen, circled in blue on the screen, you'll notice there's a list of participants. That tells you everyone who's joined the call today. If you want to speak to anyone in particular, you can use the chat function to select that person's name from the drop-down list and then type your message. But I would really encourage you to select everyone from the chat function and then type your message so that everyone can get involved in the conversation. Okay, so you should now be able to, on the top left-hand side of your screen, see a blue arrow that's highlighted. If you can click on that for me, what I'd like to do is try and see where everyone's calling us from. So now if you can click on the map where it is that you're joining us from. We're going to get a lot of overlapping arrows over.
Yeah, we've got a lot of people obviously in Scotland, and we've got Angela over in the eastern seaboard of the States, and our speakers over there as well. We'll bring him in later. Mary Nolan is on the next page. Well done, Mary. But we're pleased to see so many people being involved in the WebEx today.
Thanks, Ben.
Thank you, Lisa. So what we have here is an opportunity to engage with clinicians and even beyond clinicians. But this is the link to our clinical engagement strategy here at Healthcare Improvement Scotland, and it's from this strategy that this series was developed. And Jennifer Graham, who's with us today, came up with the idea of the QI Connect series. However, in addition to engaging with clinicians, as you can see, there are many other people and organizations who've shown an interest in this series, and these are just some of the organizations who are joining us either live today or will be listening to the recording. And we've spoken about some of these organizations in the previous series. I'm also delighted to say that we need 2 slides now for all the organizations that are joining us, and this is the second slide. You can see the Health Foundation on there, the Clinical Excellence Commission down in New South Wales, in Australia, and colleagues from across Scotland, England and Wales. I'm particularly pleased to call out some of our new attendees. Our usual stalwarts, the University of Dundee and the University of West of Scotland, have now been joined by colleagues from the University of Stirling and indeed from Edinburgh Napier University. So welcome to our university folks. The IHI Open School in Dundee, where the students are learning about quality improvement, are great supporters of the series, and welcome to today. We also have colleagues from the 1,000 Lives campaign and from NHS Wales, colleagues from the private sector hospitals in BMI up in sunny Aberdeen, and colleagues from NHS England from Merseyside and Stockport. So welcome to you. We're also delighted to say that our reach is now more than the 38 countries both linking in today and through the WEBEX series and also through the HUE Fellowship Program, we're now reaching almost 40 countries. And we have a competition for those on the call today, so stay awake. Here's the competition. We're offering a copy of Don Berwick's Promising Care book. Now this will require you to use your blue buttons again, your arrows. And our colleagues are joining us from Peru today, so I'd like to welcome our colleague from Peru. And the competition, it's Juan Limo from Peru, and I would like you to, the first person to click the blue arrow on the Peruvian flag wins the prize. So Jennifer, stay awake. Here we go. Paul Gimson, close but no cigar. Michelle De Felice. Well done, Michelle. Michelle De Felice has won the prize. So we'll send that off to Michelle. I'm not quite sure how that happened, but we're delighted that Michelle won the prize for the copy of Promising Care, Don Berwick's latest book. Well done, Stuart, and others who also got the Peruvian flag. So our global reach in this series is going from strength to strength, and we're delighted. And as I mentioned earlier, HUE have also used or are using the QI Connect series as an approved resource within the HUE Fellowship Program, and we're grateful to them for that. Just to remind everyone, we're recording the session today so that you can access it at a later date. And please, we're looking for you to really get the Twitter tweeting today. So that's our hashtag for today's meeting. We're going to be showing some data on Twitter at the next QI Connect webinar next month. But please start tweeting any comments. Don't put your questions on Twitter. We're looking for the questions in the chat box, as Lisa said. But let's try and get the Twitter working. And just to remind you again of the team that are here in Glasgow, with Jennifer Graham, with Lisa Birch, and with Carmen Forrest, that are keeping the show on the road here in Glasgow. Thank you to all of them for getting the show underway. I'm also particularly delighted to welcome Ian Keith on the call today. Ian is a very enthusiastic consultant physician in the Royal Alexandra Hospital in Paisley in the west of Scotland, and he is a current Scottish Patient Safety Fellow in Cohort 6 of the Patient Safety Fellowship Programme. And Ian will be leading the questions at the end of our talk today. So grateful to Ian for joining the call. Thank you, Ian. And just as a flag, as we do with all of these webinar series, just to highlight that the views expressed are those of the speakers themselves and do not necessarily represent the views of the organizations that they work for, and today is no exception in that the views do not necessarily reflect the official policy position of the Centre for Medicare and Medicaid Services. And that brings us on to today's speaker. I'm absolutely delighted. It gives me great personal pleasure to introduce a long-term friend of mine, Dr. Rocco Perla. Rocco is a true polymath. He is a qualified microbiologist, a mathematician, an epistemologist, and an educationalist. He has published extensively on a whole range of topics covering that full expanse of scientific study. But today we're absolutely delighted to welcome Rocco to talk about this concept of a whole patient measure. So welcome to the call, Rocco.
Thank you for that kind introduction, Brian. It's been a pleasure and a privilege working with you and others in Scotland over the years. I'm very excited to be here today to present on a topic I've been exploring now for a little over 3 years, and I really look forward to some dialogue relative to a new way of thinking. So today I'm going to introduce you to the idea of a whole patient, or really a whole person measure, but I'm actually going to do a little bit more than that. I'm also going to take you through the thinking, really kind of the analytical journey that led us to this concept. As my team was developing this approach, every time we had a decision to make about how to proceed, we decided to ask ourselves two questions, regardless of the technical challenges that were in front of us. The first was whether or not this was meaningful to a patient, and the second was whether patients could actually understand what we were trying to do on the measurement side. It's interesting that if you ask those questions often, not just at the beginning or the end of an inquiry or process, you end up in a very different place with new insights and views about what's important. And I think at the end of the day, that's really what we want to focus on. So everyone working to improve healthcare recognizes the central role that measurement plays in guiding our efforts. There's no question about that. But in a rather odd way, the healthcare industry, with nothing but good intent, I think, has made the measures themselves the fundamental unit of analysis, not the patients. And this is a subtle difference, but a profound one, I think, as well. And if we ask, why is that the case? And I think it's because it's easier to measure parts than wholes. In fact, much of the data infrastructure that we have to measure focuses on particular conditions or care pathways. And then the assumption is that if the parts are all in good order, the wholes must be too. And I think we know that upon reflection, that's probably not a safe assumption, and we've got a number of experiences to suggest that's the case. So I'm going to share three key ideas. These are very high-level concepts, and as I go through my presentation, you may want to come back to these because they're anchoring ideas. The first is that healthcare measures tend to focus on fragments of care, not whole patients as they move through the care system. And if you agree with that, or think there's some validity to that, then the challenge in front of us is whether or not we can rethink how and why we measure safety in health systems and shift to making the patient the fundamental unit of analysis. Now, unlike many analysts and evaluators, I'll be the first to tell you I think the specifics of my model are wrong. They're not perfect, and they're subject to modification. But it's not. This talk is not about the measure. It's about more of a shift in thinking or even a movement about how we view and develop measures for the benefit of understanding the true safety of health systems and hospitals. So I'm going to share a quick story with you because this whole patient measure is actually grounded in experience, a personal experience. I sat on a hospital board as a member of the subcommittee. I was the lead analyst, and we were having a discussion about the proliferation of publicly reported measures, both on the quality and the safety front. And many of the board members were very concerned about conflicting results that were generating confusion within the hospital and indeed the community. If you looked at some of the measures that were provided by some agencies or groups, we were doing very well in the area of safety and quality. And if you looked at other indices, we weren't doing so well. So what was the truth? How could we actually get to the truth? In addition to that, the hospital recently had 2 mental health patients that were in acute crisis that were in the emergency department. They evaded the safety staff that was caring for them, and they did significant harm to themselves and others, damaged property, and it was really an opportunity for everyone to think about, where are we in terms of our journey towards the safest environment we could create. So it was a very sensitive time for leadership, and there was not a lot of patience for analytic jargon. So this is just a very quick example of a dialogue I had with one of the members of the Board of Trustees that I attribute the beginning of this thinking to. The member of the board asked me, how regularly do bad things happen to our patients? And of course, as a statistician and an analyst, I wanted to dig into what she was talking about, and I asked, what's a bad thing? And her reply, I thought, was just brilliant and put me on my head. She said, it's anything that should keep me up at night, really bad stuff that shouldn't happen to anyone, and don't give me any of that risk adjustment crap. Now, this person I'll also mention was a nurse and a well-respected clinician in the community. She knew well the virtues of risk adjustment, but at the same time, she also wanted to cut to the chase and understand whether or not the environment we had was safe at an intuitive, visceral level, not just at an analytic level. And I think that's one of the challenges of the measurement and improvement, and one of the things that we really need to take a good hard look at. So this is just a sampling of the sorts of data that was coming into the hospital. And what you'll notice here is that on 2 of the measures, the health system was doing worse than average. On 2 of the measures, they were at average. And on 2 of the measures, they were better than average. So the challenge is, how do you make sense of this data? How do you reconcile this back to an individual patient? Is that even possible? Now, if you look at the disclaimers that are provided on many of these measures, they're very fair in their assessment and remind us that each patient safety indicator is rated independently, and some indicators may apply to more patients than others. And actually, I think that's part of the challenge in front of us, not to just qualify that, but to think about the implications of what that means. This is another sophisticated metric that the health system was using to understand where they are. And just to make things very simple, on the vertical axis we have the 5-year rate of improvement, and on the horizontal axis we have the current year performance. So ideally, you want to be up in that upper right-hand quadrant along a number of different measures that are represented in the bubbles. So you want to be in that right quadrant because that means not only are you doing well, but you're getting better versus not doing so well and getting worse. I've had many people tell me it's really hard to understand how this actually links back to a patient. If we look at some of the work by the Leapfrog group, they too will remind us that patients should choose a hospital that has a small number of patients who are injured during hospital stay, who get pressure ulcers, who experience never events. And I think we all recognize that as being very important information as patients, but the question that I wanted to entertain was, how many patients go through an admission and experience none of that sort of stuff? Not just looking at it individually. If we look at national sources of data, the quality of the data has improved steadily over time, and in fact, within the U.S. Department of Health and Human Services, we have good information on hospital-acquired conditions, various patient safety indicators, serious complications, and death. But here again, as a reflection of the industry, the focus is on the rate of specific conditions, not the risk of acquiring any of these conditions during the care experience. And that's the pivot that we're making with the whole patient measure. All right, so it's good to know things, and we do know things. The first thing we know is that patient safety data is everywhere. The amount of information that leaders are asked to process and act on is growing every day. The second point is that administrative data is not going away. There are many countries and organizations that use administrative data to do lots of things. It's a rich source of information in terms of claims, volume, utilization, as well as quality and safety, and I think it's generally getting better over time. We also know that there are lots of claims about top performers. So it's hard not to go into a hospital or health system and see plaques on the wall lauding their performance in a number of different categories. But at the end of the day, I think we have to ask ourselves, how meaningful are all of those measures and metrics? Do they really get to this idea of visceral harm and concern that patients have? I think for anyone who's involved in patient literacy, there's no question that we overestimate what patients can actually understand by a long shot. So if you think about information and shared decision-making, how accessible do we make the information that patients could use in order to make good healthcare decisions? The last point here is that we don't measure over time, we measure points in time. I think this has generally gotten better with the movement towards time series data and quality improvement in general, but the real key message here is that we don't measure whole patients, we measure fragments of care. Now, if we look at this picture, we can see a patient. It could be your grandfather, your father, your brother, your uncle. And as a patient, we all want to be treated in a way that's respectful, civilly. We want to be treated with kindness. We also want to make sure that the care we receive is standard-based and that we're not being experimented on. But if you take a good look into this gentleman's eyes, there's this element of vulnerability. And so the one thing we want from the health system, above and beyond everything else, sort of the first order principle, is not to be harmed by the system that's designed to help us. And so although people will not generally say this, they're scared to go into hospitals and health systems because there is an invasive aspect to care that we all know is a possibility, and it worries us. The problem here and the challenge is that we will never measure this individual or anyone else as a whole. What we will do is we will divide his care and his experience up into a number of different conditions. And this individual, like all of us, may or may not be included as a numerator or denominator in any one of these particular measures. But the issue here is that we never reconcile those individual metrics back to the patient. And that's the primary challenge, is that we live primarily in these analytic buckets without recognizing that there is a whole patient and an experience that really needs to be understood. So this doesn't just create a conceptual or ethical dilemma, it also creates some very interesting anomalies statistically. And I'm going to share with you what I've called the Fragment Fallacy. It's a very simple exercise to show you how distorted measurement can be when we don't take this whole patient perspective. Across the top row, we have boxes in purple that are listed M1 to M10, and those stand for 10 measures. So measure 1, measure 2, all the way to measure 10. On the vertical column, we've got 10 patients, so patient 1 through patient 10. Now, let's just focus on the measures for now. And let's further assume that if we populate this table with these X's, that every one of those X's represents a deficient case. So if we read this table from top to bottom, and our focus is just on the measures, we would produce percentages of compliance of 90% across the board for all 10 measures. We could look at the data a different way. We could say we're a patient-centered organization. Let's focus on patients. And so we focus on patients and read the table horizontally, and we end up with the same metrics, 90%. Now, I don't know about all of you, but 90% are good. They're A-minuses in most school systems, and if you show 90% to boards, they might say, well, you know, we could do a little bit better, but, you know, we're making headway, and that's not a bad starting point. The reality here is that patient compliance is indeed 90%, measure compliance is indeed 90%, but defect-free patients through the system is 0%. So we often wonder and discuss in health systems how patient satisfaction scores can be increased and improved. Well, part of the problem is we don't have the right lens. We're maybe asking the right question in terms of experience, but we're not measuring that experience. We're measuring the fragments of care that never aggregate or reconcile back to the whole patient. So enter in the whole patient measure of safety, which was the approach that my team developed to try to address this issue and to provide a different way of looking at the same problem. The focus of the whole patient measure is on the entire care experience as defined through a hospitalization. We were looking to identify a set of highly undesirable events. We wanted to use terms that were plain English so anyone could understand, and we pilot tested this, and highly undesirable was something people actually can understand. So it's not really a medical term. And these were events that could happen in theory to any patient during a hospitalization. So in that sense, we were really after a global measure. Now, one of the criticisms of these sorts of measures is that there is still some debate about what's preventable and what's not. So we chose to focus on really bad things. Here again is plain English, and wanted to wipe out that gray area. So if there were conditions that people would debate and argue in terms of preventability, we wanted to take that out of the equation and focus on some really egregious things. I had the good fortune of working with UHC, the University Health System Consortium folks, which is one of the largest private sources of claims data in the United States. So we had a large, robust data set to work with. And the trigger here was the present on admission flag. That's what POA stands for. And that present on admission flag had to be N or U, so no or unknown. And if you think about it, obviously we want to capture things that were not present on admission but were acquired through the admission. All right, so this is the table. These are the 14 highly undesirable events the clinical team that we consulted came up with. I am absolutely sure that these 14 events are incomplete, possibly inaccurate. There should be things added. There may be things that should be deleted or taken out, whatever. That's not the point. The challenge here is that if we can come up operationally with a set of undesirable events that no general inpatient should ever experience, then the challenge is, can we think of these things as one event? Recognizing quite clearly that there's a differential degree of risk. So yes, some patients will have a higher risk of fall with trauma. Some will have a higher risk of pressure ulcer or poor glycemic control. But can we think a little bit differently and say that regardless of that differential degree, none of these things should happen to anyone? And if we can do that, we can ask a very powerful question. And it's the question that we ask in the whole patient measure of safety, and that is, what proportion of hospitalized patients experience at least one of these highly undesirable events during their hospitalization? All you need is one. If you have one, you have not been cared for in a way that we would define as safe based on that table of events. So I'm not a great artist, but I'm just trying to pictorially demonstrate the general rhythm of what happens in hospitals and health systems. People generally are admitted and they leave. And so the question is, can you get through your admission with none of these events occurring, or at least one? So for the sake of this part of the measure, it doesn't matter if you've had 5 or 6 of these occur. The question is one or none. And I like to remind people that, again, with the skull and crossbones, that patients are actually, they are concerned, and they do have that element of fear, and there's a visceral sort of association with health care and safety. So again, back to my colleagues in the area of patient literacy, I pilot tested some of these ideas with nursing home residents and elderly folks in assisted living centers, and I wanted to get to what they understood. And I found that they really couldn't understand a lot of the data that was being intended for them to make decisions. I'm not sure patients can understand much more than this. Something like, for every 100 patients admitted, how many have something really bad happen to them before they leave? Now, all things being equal, I think you'd be hard-pressed to line up to Hospital B. I think many hospitals would want maybe to go and take their chances at Hospital A and D. But this basic level of information is not provided for any patient anywhere that I know of, other than through this sort of a measure. So the results here are exploratory, and they're exploratory for a good reason. This was our first pass at the analysis to really kind of operationalize the concept. As I mentioned earlier, we were very fortunate to have a large, robust database. We had 161 hospitals in the United States. We looked at the data across a 2-year period. Initially, we didn't do any case mix or risk adjustment, although we've toyed with that subsequently. And the reason for that is we wanted to take just a pure look at the data. What does the data look like if we don't do any sort of adjustments? We had over 6.5 million discharges, so definitely a healthy number of observations. And then we did some basic descriptive statistics. We looked at cost and length of stay. And then we also looked at data over time using statistical process control techniques, which are now becoming, I think, one of the dominant analytic methods in healthcare. And so this is our distribution. And just let me orient you here. On the vertical axis, we've got the number of hospitals. There are the 161 hospitals. And on the horizontal, we've got the percent. So these are the percent admissions with at least one HUE for every one of those 161 hospitals during that 24-month study period. And what we can see here is a distribution that's relatively normal-looking, or Gaussian. But of note, we have, to the left, you can see I've noted we've got 5 hospitals with a rate of less than or equal to 2%. So these are 5 hospitals that if you took that 24 months of data and combined it, their rate was less than or equal to 2%. To the far right, we have 3 hospitals with a rate of greater than or equal to 12%. So you can see the range there is, I think, is noteworthy. Of course, back to the question I have and always ask is, where are the best-rated hospitals in this distribution? You know, would the placards and the awards match the distribution here? And I think that's the question that helps. It's an issue that we deal with in measurement circles. It's the notion of construct validity. If you measure the concept like safety 3 different ways, do you come out the same 3 different times or not? And that's something that the healthcare analytic environment hasn't really addressed much to date. So now this is the statistical process control analysis, and what we did here is that we combined all of the data and looked at it over time, and we were fortunate enough to look at the data monthly. And so what you're looking at are basically the percentage of hospitalizations with at least one of these events by month for all the hospitals. And it's interesting to note this decline from July of 2008 all the way to about, I think, March of 2009. Some people have suggested, although we haven't confirmed this, that might be the consequence of more aggressive coding. So if you are identifying conditions that are present on admission, so it equals yes, your rates will go down. But we did also observe that the last 18 months worth of data were remarkably stable. So that's the high-level aggregate, all the hospitals combined. We then looked at the data doing what I call a range analysis. So we took 2 hospitals that were very similar in terms of size, scope, care pathways and things like that, and looked at them using SBC methods. And what we noted here, I think, was quite interesting. 2 points to make. The first is that the rate of HUEs for Hospital A is much higher than Hospital B. Not only that, the data is consistent over time. So for those of you that are familiar with this type of analysis, if there was an unusual pattern that was non-random, those blue dots would be red to signal an unusual pattern. So basically what we're seeing here is not only a difference in rates that looks quite important, but also the fact that the data is stable over time. We then looked at the same data, but we pulled out, in terms of a subgroup analysis, only our elderly patients who are greater than or equal to 65. These are the same two hospitals, and we see the same sort of trend as we would expect, both stable and Hospital A with a much higher rate than Hospital B. I would also point out that the red lines, the control limits here, are a little bit wider than they were in the previous slide because we've got a smaller subgroup. So every one of these observations per month is smaller, which makes the confidence interval wider. Now, I mentioned we also looked at cost and length of stay, and here what we're seeing is the relationship between the number of HUEs per hospitalization. So I want to stress that. This is per hospitalization, and then the average total direct cost. And sometimes I'm interested, when I show this slide at meetings, people will want to get into the cost modeling that was used. And I can tell you that the model that was used by UHC is very comprehensive and sophisticated, takes into account things like geographic variation and the area wage index. But the one thing that's surprising is no one seems to be too alarmed that there are actually some patients who have 6 of these really bad things happen during a single hospitalization. So all of us in quality improvement have been trained on the Swiss cheese model of harm, which basically says, you know, if everything lines up in the wrong way, you can get all the holes of subsequent pieces of cheese to line up and a catastrophe can happen. These are patients that, for all intents and purposes, they go through the Swiss cheese model of harm 6 times, and I think that's quite significant. So when people look at this data and they ask me, well, this is all interesting, Rocco, but how do you use this data? I'm stunned, because if I were a risk manager in a hospital or health system, I would want to see every one of my patients that had 3 or more, let's say, of these HUEs during a single hospitalization. I'd want to do 2 things. I'd want to confirm that the coding was accurate and that, you know, these things really did happen. And the second is I'd want to study my process, because these are patients that basically trip every trigger, negative trigger within the institution, and so there's an opportunity here for tremendous learning. But we don't have access to that because we don't really look at the data in that way. We also looked at the number of these events documented during a hospitalization and the average length of stay. We looked at overall average length of stay as well as the mean intensive care unit days. And we see here something we would expect, and that is as the number of HUEs go up, so does the length of stay. We're not really sure about the directionality here. Is it a question of an increased length of stay increases your risk for more HUEs, or more HUEs increases your length of stay? It's an interesting thing to explore, but in reality, if we're truly in a safe environment, whether you're in a hospital for 3 days or 30 days, should you expect to have any of these things happen? I think that's the more important question. So this is where things get very exciting. I'm going to shift gears a little bit, because there is growing momentum here among major health systems that I've communicated with, states, regions, and even countries. And there's the recognition that this sort of approach is important. And so when I talked earlier about my model not being, the perfect model or the right model, and I mentioned that this was more of a shift in thinking or a movement, this is the sort of stuff I was addressing. So for those of you in England will know this well. This is work that is very consistent in spirit with the work of the whole patient measure of safety. It's a safety thermometer that was developed by Power and colleagues in England, and their approach here is basically to define harm-free care. And they're saying that harm-free care means that a patient will be protected from every one of these 4 conditions: pressure ulcer, fall with harm, UTI or catheter-associated urinary tract infection, or VTE. If you are protected from 3 of these but not the 4th, you're not harm-free. And I think that makes a lot of sense. So it's interesting that this model was developed around the same time my model was developed, and I was focusing more administrative claims data where the safety thermometer is focused on clinical audits and as close to real time as possible. Now, I put this quote up here by a patient to the right just to remind us of how we may be drifting in the wrong direction. This patient says, "Don't keep me free from pressure ulcers, but let me get a urine infection. Protect me from all these harms and keep me harm-free." I can only imagine what the patient here must have thought in terms of needing to actually have to say that. This is work from the Netherlands, which I'm very excited about. I think this is a fantastic twist on, again, this whole patient approach. The researchers here were looking at desired outcomes of care after colon cancer resection, what they call textbook outcomes. And so I know there's a lot of focus on mortality, and I think there should be. But if we look here on the conditional side of this table, which is really informative, we see that 95% of patients survived, but less than half experienced a textbook outcome. So again, when we think about are we serving the needs of our patients in a way that is safe and effective and efficient and quality-driven, it's this sort of information that we have to get at. Because if we're focusing on high-level metrics, things like mortality, which are informative, we may be losing lots of valuable information about the process that underlies the rest of the experience. So I feel like I'm driving a standard car here because I'm going to shift gears one more time into what I think is the most interesting aspect of this concept, and that is this broader measurement perspective. Now, I can tell you that in the United States and certainly in other countries, there's been this shift from focusing on healthcare as a hospital-centric initiative, broadening gradually into medical homes and medical neighborhoods, evolving into a focus on accountable care organizations and other sorts of initiatives that look to address the geographic variation and quality and cost of care, all the way to the holy grail of what I think measurement needs to focus on, and that's population health. And I attribute this perspective to one of my colleagues at Kaiser Permanente, Matt Stiefel, who said, whenever you do anything, think about the population. And it's that insight that really led to this broader thinking. So we can go back to that visual, and we can reframe the question. Whereas before we were asking, what is a safe hospital, can we ask, what is a safe society or social structure? So we can replace a lot of those clinical conditions that we had in there earlier with issues of great importance in terms of well-being of individuals. And the thinking here is that if any one of these is out of whack, there's going to be a significant risk to the individual to be a successful and productive member of society. Of course, this approach requires data integration, and that's not an easy thing. And I would say as we move into this new potential of population health and measuring whole patients and people, we need to think carefully about what data integration means across sectors. We have to focus on actual people who are moving across and within actual systems. And so even with cross-sector data, you have to ask the right question. And that question comes from leadership. And then everything else needs to rally around that sort of vision. And the data has to serve the mission and the vision, not the other way around. So just to summarize some of my key points, I think we need to focus on whole patients and citizens as they move through the system of care in our social structures. On the administrative data front, I think it's important to recognize that manual review of high-volume data is not viable, and I think it's almost impossible to integrate across sectors. We can use sampling schemes and strategies, and those need to be and are being considered, but administrative data, I think, is a rich source of information, particularly cross-sector. And then the last idea here, to just put a point on this idea, the concept is more important than any one application. So how could you take this idea and apply it to your own setting? So I've talked to chief executives who said, I really like your system-level view, that high-level view, but I can imagine breaking this down and looking at it also by service lines, where we adjust the highly undesirable events by service line. I've had chairs of service tell me that they could use this in their diabetes clinic or in their heart failure clinic, where there were a few things that they know none of their patients going through their outpatient clinic, for example, should ever experience. And then finally, I think the real challenge is identifying population health milestones and aligning accountability in terms of the social services we provide with the measurements we use, recognizing that we're dealing with whole people, not just with fragments of experience. So this is the last slide, and I throw it out there as a possible exercise or maybe even a challenge, considering that improvement is about action and change. In 1 month, can any of you out there identify a clinical process or care pathway that you're very interested in? From that, define the ideal experience or outcome, then identify the events, negative events that could occur, measure that either through administrative data or case note review, share results with the appropriate teams, and identify 2 or 3 changes that you could test to improve the outcome or process. So it fits into the idea of measuring for improvement. And I think my final point here before we open it up for discussion is that we talk a lot in healthcare about measuring what matters. I would argue we need to measure who matters, and that's a shift in thinking I think is happening now. Thank you very much.
Rocco, thank you so much. That was absolutely fantastic. Really, you covered a lot of key aspects there and did it very, very nicely. And the chat box has been buzzing. So you talked about how measurement matters. You've talked about how it's been sometimes poorly understood, even by your board of trustees, and that would be the equivalent of our non-executives here in Scotland. We are good at measuring things, or we can be good at measuring things, but not necessarily measuring people, and that's what really matters. And I love your fragmentation fallacy. I'm sure we'll hear more about that. So I'm going to hand you over to Ian now. So Ian, you've been listening intently to what Rocco has to say. Questions, thoughts?
Yeah, great talk. Thank you very much. I'm just wondering how, obviously there's a lot of chat on the box about how we can use this in our healthcare system. How can you ensure that this big data and all the data we're providing is used for improvement rather than punishment of the organisations and the clinicians involved? Obviously, the hospital with 12% harm rate would obviously be punished or was sick in this society.
Right. Thank you, Ian. And that is a great question. I get asked that a lot. And, I go back to the idea that this measure was developed with patients in mind. And I think whatever regulatory or accountability model or scheme that's developed really needs to be done in partnership with providers and patients in order to ensure that what's being measured is meaningful and can also support improvement and transparency. So, the idea of getting patients engaged, the idea of data transparency, the idea of improvement, I think those are the overriding principles that trump kind of the negative connotations to measurement that have been, part of our history. And I think part of the shift in thinking is being as creative as we can, that we begin to balance that accountability, but do it in a way that's productive, transparent, and involves the patient.
Thanks very much for that, Rocco. Now, let's just go to some more questions. I know, Ian, you've probably got more questions, but let's just pick up some of the questions that have been in the chat. So, Rocco, as you've been talking, a number of folks on the call, including Fiona Mitchell from NHS Grampian, have been talking again about the person-centred care and the patient experience. And Rafe Roberts, who's the Chief Executive of NHS Shetland here, has asked a question, and he says, is there any correlation between the relative rates of highly undesirable events with qualitative assessment of care by patients, so patient experience and HUEs?
Brian, another great question, and we get that question often too. We're actually just beginning to explore that, this relationship between relative magnitude and impact of HUEs and patient experience, and we think that's an important thing to understand further. Right now we don't have any data on that, but it's something that we are actively engaged in learning.
Thanks, Rocco. I've got a question here from Alison Hunter, who's one of the National Improvement Advisors here at Healthcare Improvement Scotland and leading on a lot of the safety work in the safety programme. And Alison's interested in the NHS thermometer work in England, which we've looked at previously, and when they do their measurement, they do it by sampling, I think on a monthly basis. Do you have any views on the value of sampling over whole numbers, if you like, from your study? It's looking at all of the things that happened, whereas the thermometer looks at sampling. Any views on the relative merits of those approaches?
Yeah, absolutely. So sampling can and actually should be done. I think it makes a lot of sense to do so. And it's interesting, a lot of people may not realize this, but there are ways to actually calculate the power of a time series or SPC chart based on the sample size. So one of the things that people are often concerned about is that if their sample size isn't big enough, they don't get upper and lower control limits on those time series charts. But there are very simple methods and heuristics, I've actually helped develop a couple of them, that can be used to help you determine what your sample size should be in order to get those limits and to construct a proper time series graph. And it also takes into account an estimate of the current rate of defect, which is part of any standard power calculation. But as far as on principle, sampling makes a lot of sense, and I think in situations and environments where it can be done, it should be.
Thanks for that, Rocco. A number of the folks on the chat have been asking about, again, going into the person-centered measurement and measuring what happens to me. Any comments on the measurement of what matters to me? Any thoughts around who's doing that best, who's doing that sort of measure?
Yeah, I think as I noted earlier, there's a lot of a groundswell and interest in this idea, and I think we're just now starting to see this idea of what matters to me be translated into measurement ideas and concepts. So it's one thing to say that healthcare is moving toward patient-centered care and we're focused on the patients, but until the measurement paradigms actually align with that, we're not really practicing what we preach. And so that's one of the things that makes me so excited about this sort of work, and the basic concept is I think it moves us in that direction, that we can more meaningfully answer that question, what matters to me, and people we love and care for.
Yeah, thanks, Rocco. And we've also had comments from Davey Thompson, who leads a lot of our integrated pathways work in mental health, saying that we should be developing more of a measurement framework around what matters to me. And also comments from the Improvement Academy from the NHS Tayside, who've also been raising the same question. So clearly people are trying to think differently about that measurement piece. Now, Ian, you have another question you want to put to Rocco?
I do. Obviously, the patient is obviously the key in all these conversations we're having and what we do. But what obligation does the organisation or the clinician say to actually inform the patient that you've had an undesirable event, and especially if you've had 6 events in one? And also, do we have an obligation to compensate them for the harm we've given them while staying in hospital for a week, 2 weeks, and everything else, all the associated costs with that? And what's your thoughts on that?
Yeah, I think that's a very important consideration. I actually think the obligation we have to providers is to provide them with meaningful data. I think we provide clinicians and other providers in the healthcare sector lots of information they find meaningless or useless, and if we focus on what's important to the patient, I think what I found is that that translates into what's meaningful for the providers as well. The example I shared at the end of my talk, where I had chiefs of service come up to me who were running clinics saying, I know that if a patient goes through my diabetes clinic, there's 4 things, I can tell you them right now off the top of my head what they are, that I would never want them to experience, but they could, and I have no idea what that rate is or how many of my patients actually don't receive what the folks in the Netherlands would call textbook outcome. So I think I do think as leaders we have an obligation to providers to give them the most meaningful data that's actual, that can drive improvement and really begin to sort of transform the systems we work in.
Thanks for that, Rocco, and thanks, Ian. I may come back to you in a moment. But I see again from some of the chat that, Rocco, this data that you've talked about, these 6.5 million discharges, which is an amazing N, you get that from administrative data, right?
That's correct.
Yeah. So certainly in Scotland, we don't collect a lot of that data. In terms of the sort of things you would refer to as a highly undesirable clinical event. So are you saying that this is widely available in the US? And if so, is that because it was mandated?
No. So the data that we collected is actually was stored by a private company. So UHC is a private company, and you pay into the service to participate in their program, and you can get that sort of information by reaching out to them and asking them. So the measure really hasn't gone much further than that. So there's no mandate associated with the measure. And we just happen to have that data available, and I had a very skilled team of analysts working with me at UHC and others that could actually retrieve this data and then write the queries that would determine the percentage of patients that actually received an event during admission. So the infrastructure, even for this measure, I think would need to be developed and validated as well, and we're doing some of that work on the back end. So it's still a relatively new idea, I would say, even within the United States. And the other point, Brian, to the observation about the data you have available being maybe more limited on the claims front, I think that's more of a reason to seriously consider sampling algorithms and using real-time clinical data. There's multiple ways to get to the same point where the focus is actually on the patient's entire experience as they move through the care system.
Thanks for that, Rocco. And just on that point, I mean, for regulars in the QI Connect series, both Professor Sir Mike Richards from the CQC in England and also Elaine Inglesby-Burke from England, the nurse director from NHS England, will be touching on this new introduction of the duty of candour in NHS England and I think NHS Wales, where the NHS in England will be compelled under the law to disclose events, including that long list of HUIs that you have outlined, Rocco. So that's a new development on the back of the Mid-Staffordshire. So Ian, just before, so you'll hear that more of that later on in the series, later in the year. That's October and November. But Ian, last question to you.
Yes, obviously in industry such as Tesco, I'm not sure if you've got Tesco in America, but they can give you individualised offers to your shopping using big data projects, and so do Google. Should we be reaching out to industry? Have got vast computer banks and data banks to use the word big data to sift through the data real time to give individualised reports to the clinicians. So if they go out with their SPC and more harm's occurring, then we can stop that happening quickly, not only in an organisational group but also individual clinicians.
So I have a thought on that. It's a great question. It's something I've been exploring for a while. I think that the big data companies and industries, they are fabulous at storage, retrieval, and a number of other sort of technical activities. I actually see a huge void, even in these large private industries, in terms of the analytics. So there's a lot of talk about business analytics and business intelligence, but if I've yet to find a big data company that has actually embedded sort of an SPC approach into the work they're doing. I think it is a ripe area of opportunity. Typically what we see on these back-end analytics are things that are not what we would associate with kind of the healthcare data movement in terms of analytics. It is probably one of the most significant areas of opportunity that we have in front of us that hasn't been realized.
Thanks for that, Ian, and thanks, Rocco. Rocco, we have a final question here. I think we've got a whole bunch of questions coming in, but from Susan Bishop, who is the national lead at the Quest in Scottish Government, a national improvement lead. She makes a point to your last few slides around how we could be looking wider than just healthcare. And she says that she was at a session today looking at health and telecare, a workshop this morning, telehealth and telecare, with people from health, social care, housing and third sector, that's the voluntary sector. And she would see this as a great opportunity to be asking people what should be measured across those silos. So it sounds as though your stimulus to think more widely and to look across the silos has landed well here in Scotland. So, Rocco, we're coming near the top of the hour, and I would like to thank you on behalf of not just Healthcare Improvement Scotland, but also NHS Scotland and all of our listeners and regulars now in the QI Connect series for a wonderful exposure to the field of measuring things that really matter at a patient level. So thank you very much for that, Rocco. Now, what I'd like to say, just to remind you of Rocco's challenge here, or his exercise is set for you. So can you identify any of these things or measure these things in the next month? So these slides will be made available. Carmen will be posting these up shortly. So take a look at that exercise, and if you do that exercise, if any of you take on Rocco's challenge, then please share your results. Share them with Jennifer Graham, and again, her email address will be on the slides that come out to you. And we would love to hear about that, and we'll share those tests with Rocco, and we'll talk a little bit about them at the beginning of the next QI Connect webinar. And it's with great pleasure that I can announce that the next QI Connect webinar will be on the 30th of July, and we have yet another international leader in quality improvement, Dr. Gary Kaplan. Gary is the Chairman and Chief Executive of the Virginia Mason Health Systems in Seattle in Northwest America. He's a practicing physician in the Virginia Mason system, and he's been heavily involved in quality improvement and is currently the chair of the IHI board. So you don't get much more experience than that. Also to say that we're absolutely delighted that Gary and his team have been working in Scotland, along with the leadership in Elaine Mead and her team up in NHS Highland. So we're delighted that Elaine will be joining us for the next QI Connect series to engage with us in the questions for Gary. So we'll be announcing more about the topic of Gary's talk in due course, but please put that in your diary. And please share the word about the QI Connect series. So as the clock ticks on to the top of the hour, I'd like to thank everyone involved in the series, to Lisa Birch, to Carmen Forrest, to Jennifer Graham, to Ian Keith, who's been outstanding in his questions and has really matched very nicely Rocco's talk today. And it's to a big thanks to Rocco Perla for sharing his thoughts and answering our questions today. So, safe journey home if you're going home, folks. Have a great day if you're starting the day. And please join us for the next QI Connect webinar. Thank you very much indeed.